Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has muted, so we have our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we would like to ask you to help us complete. Your feedback is important to us as we plan future programs. Next, I would like to introduce you all to today's guest speaker. Joining us today, we have Dr. Giovanna Manzano. Dr. Manzano is a multiple sclerosis specialist, neuroimmunologist, and neurohospitalist who sees patients at Mass General Hospital and Brigham and Women's Hospital. She is the Director of Quality Improvement of the MGH Neurology Department's Division of Neuroimmunologic and Neuroinfectious Diseases, and is also teaching faculty for the Mass General Brigham Neurology residents and Harvard Medical School students during the neurology clerkship at Brigham and Women's Hospital. She joins us today to give a talk on multiple sclerosis. So please join me in welcoming Dr. Manzano.
So thank you all for joining today's webinar. I'm very excited to speak with you about multiple sclerosis. What we're going to do is we're going to really start with a broad overview of what is MS, and then take a deeper look at what we can do to treat MS and what's being researched in this field. So here on this slide is just an outline of what I hope to accomplish today. For many of you joining, you may have multiple sclerosis or know someone who does. Or you may just be attending because you're interested. So I hope that the various components of today's talk will be helpful and educational for you all for these various different domains here. And if you have any questions about anything that's covered, as Amy mentioned, please do submit them. We will be saving questions towards the end of this talk. So to start us off, what is multiple sclerosis? So multiple sclerosis really means multiple scars. And the reason for that is our understanding of the condition is that there is some immune dysregulation that occurs. The reason why is something that is very much under investigation. And later in this talk, we're going to go over some hypotheses that we have in research and what's being discovered and what's understood so far. But on a very mechanistic, basic level, what we know is that in our immune system, we have essentially two large arms. We have our B cells, which are antibody-making cells that protect us from things that we may have seen before. And then we have our T cells, which you can think of are your first-line soldiers ready to fight off whatever infection or pathogen is coming your way. In autoimmune conditions, which multiple sclerosis technically could be considered, we have some dysregulation of these immune cells in that they act against ourselves. And so what you can see on this figure here is that you have this area of a nerve that's covered and insulated with these red rectangles without any damage. But then next to it, you have this picture here where you can actually see the blue nerve being exposed underneath these blocks of rectangles. And this is depicting demyelination. And that's a term that we use to describe the destruction of the myelin, this sheath covering that we have over our nerves. That's a consequence of our immune system not behaving appropriately and mistakenly recognizing self as bad. And so that is our very basic understanding of what could happen in MS to then cause what you're going to hear throughout your care with a provider as lesions. And lesions, they're not actual masses, they're not anything palpable, but rather they're scars. And so when the myelin is affected, it causes these scars, which you're going to hear me use the term lesions on our imaging. And the reason that we know that MS attacks the brain and the spinal cord, as well as the optic nerve, which is the nerve that we need to see vision and to appreciate color with our eyes, well, is that because this is where myelin is. And so that is why MS attacks in these areas. In the past years, we also have come to appreciate that there may be a component of MS that we don't understand and we can't image as well with our current technology. So there is a degenerative component, and that oftentimes is more responsible for the progressive types of MS, which we will dive deeper into later. So this is just a very broad overview of the science, which informs the treatment that we later give once a diagnosis is made. So thinking about MS and who it affects and how prevalent is it, this is a nice picture that I took from the National MS Society, which if you're not familiar with, I highly recommend taking a look at that website and becoming familiar with that organization, particularly if you have MS or you are a caretaker of someone who does, as the National MS Society does an amazing job taking a lot of information and making it friendly for both patients as well as care providers. And so what we've learned in many studies is that in the US alone, we have nearly 1 million people with MS. So of the neuroimmunologic conditions that I take care of and that we know about, MS really is the most prevalent. It does tend to affect women more than men, oftentimes in a 2-to-1 or even a 3-to-1 ratio, depending on where we're looking. And as you might appreciate from this graph, it's really more of the northern part of the US, which is in line with our understanding that the northern hemisphere actually is where there is an increased prevalence of MS. And the reason being is we think that there could be some addition of vitamin D deficiency at play on top of some epigenetics. So there are a lot of different effects and a lot of different reasons that MS might come about, but this is what we describe epidemiologically. It's what's been observed. So it can affect children as well as adults. Most commonly, patients receive a diagnosis of MS between the ages of 20 to 40. Of course, that's not perfect, and there are patients who are diagnosed earlier in their youth or later even. Later diagnoses of MS tend to be patients who just had mild presentations and so didn't really seek care until things became more prevalent, or they are developing a more progressive type of MS, which we'll go into describing a bit more later. We already talked about the differences in sex, and then in terms of environmental factors. So we know that it's not as straightforward as one gene. We have identical twins that have been studied, one with MS, one without. So there is more to it than that. And so we think it's some combination of the environment, exposures, and genes. And so of these epidemiologic risk factors, we've already talked about geographic location and vitamin D. But smoking has also been an identifying risk factor to cause the onset of MS, as well as to worsen relapse and disease activity. And then EBV infection is one factor that you may have heard about recently within this past year in particular, as there was quite a large study that was done out of the VA health system that reported an incidence of patients who later developed MS actually having EBV exposure at some time predating their new diagnosis of MS. This is not necessarily a novel observation. It's something that has been studied now for a few decades, but this work really revitalized the field's interest in the role of EBV in multiple sclerosis. So definitely more to come there in terms of possible ways that now researchers might think about trying to harness EBV and being able to understand MS. So how does MS affect you? How would you know? What you can appreciate here, this is not an exhaustive list, but is a list of the more common ways that MS can cause symptoms. And of these, I'll just take a moment to go through some main points for them. But I want to just say that even though all these symptoms are listed here, this doesn't mean that if you have MS, you're going to experience each of these. Because where someone has their disease effect, and what I mean by that is where the demyelination occurs, whether that be somewhere in the brain, the spinal cord, the optic nerve, that is what then is going to translate in how you experience your MS. So for example, if you've had an attack of optic neuritis, which is the inflammation of that optic nerve, you might have experienced an episode where you had some blurriness of your vision or changes in the color of your vision or loss of vision even. If you have any strength or numbness symptoms, that could be from a lesion in your spinal cord. Most commonly, coordination and balance and vertigo all go together when there is any involvement of the cerebellum, which is this part of our brain in the back lower area here, which is super important for balance and just knowing where your body is in space. And from that structure, there are tracts that go through the spinal cord as well. So that also could be a reason why you have these symptoms. Bowel bladder dysfunction. Also, you can pinpoint to maybe somewhere in the spinal cord or even the brain. Memory, cognition, and mood are ones that are a little bit harder to really localize because we don't think that there's a particular spot per se that has been damaged in the majority of cases to then cause some issues with memory or some changes in mood. But rather, we think that perhaps these symptoms are representative of what you might hear being called gray matter symptoms, and they reflect parts of the MS disease activity that we just cannot capture that well with the current way that we are able to image patients with MS. But they certainly are well appreciated symptoms of MS that are not necessarily just reactive to the condition, but we think that MS itself has a role in causing these symptoms for some patients. And then lastly, pain and spasticity, which are oftentimes related to prior spinal cord events, which can be present for a short duration after event or may linger. And so we work with the patient to really keep an eye out for these various things, just to be sure that if any of these occur, we really take them seriously and try to assess, well, are they because of MS or are they because of something else? Because as you might appreciate, these symptoms as a whole are actually quite general, and there are many different conditions that can cause these. So having one of these symptoms does not necessarily mean that you have multiple sclerosis. Or if you have MS and you develop one of these symptoms, it doesn't necessarily mean it's because of your MS. And that's why it's so important just to share these symptoms with your provider, so that way we can do the appropriate investigation to figure out if this is your MS or not. And if so, what can we do to help make you feel better? So as you might appreciate, because there's not just one symptom that translate into a diagnosis, the diagnosis of multiple sclerosis is quite nuanced and complex and really requires a good look from a neurologist or a subspecialist who has experience in caring for these patients, because you have to not only take what a patient is experiencing, you have to think about what's happened in the past in terms of whether they've had any event even subtly before that maybe was overlooked, and piecing that all together with then their neurologic exam. Is there anything on exam that reflects a prior event or anything abnormal that makes you wonder about a more recent occurrence of disease activity? And then once we have our history and our exam, we think about, okay, well, is this MS or not? And so what tests are done to look and to answer that question? Well, at the first diagnosis, we look for what are called essentially mimickers. So conditions that can look like MS for all intents and purposes when it comes to the way that someone presents in terms of symptoms, or even conditions that can cause similar appearances on a brain MRI. And so some of these blood tests may be looking for conditions that are also in this demyelinating family. So there's one that for short is called MOGAD, and another one is called NMOSD. Those are demyelinating diseases that actually can affect our brain, spinal cord, and optic nerve, just like MS can. Those conditions actually have defined blood tests that we can send for to see if those are positive or negative. And so in the right clinical picture, your neurologist may test you for those as well to see and make sure, is this MS or is this one of these kind of cousins of MS? Sometimes even vitamin deficiencies can cause similar imaging appearances or a similar attack. And so we have to think in terms of, well, how did your symptoms come about? What was the context? And really piece together the different pieces of the puzzle to see if we have the right diagnosis. In addition to blood tests and your history and exam, we of course are going to take a look at your imaging. And so I mentioned earlier that MS affects wherever there is myelin. And so the areas where there's myelin are your brain, your cervical spine, and your thoracic spine. So that is why we do these images. Sometimes I have patients who ask me, well, what about my lumbar spine, the lower area? Well, that area actually doesn't have any myelin. So MS would not be expected to affect that part of your spinal cord, which is why that is not part of our kind of imaging approach here. The last bullet I have down here is cerebral spinal fluid. And the way that we would obtain that is through something called a lumbar puncture. If you're not familiar with what that is, essentially the lumbar puncture is a draw where we get some of the spinal fluid that essentially coats our spinal cord. And so we extract that out from the spinal column. And the reason why that can be helpful is we look for any evidence of one, alternative causes. So perhaps a patient's symptoms and their story is just a little atypical for MS. We're going to look and make sure that there isn't something else going on. And sometimes spinal fluid is the way that you need to do that. or you're getting spinal fluid to support your diagnosis of multiple sclerosis. And you might hear of the term oligoclonal bands. And oligoclonal bands are essentially proteins the antibodies make in our central nervous system that are evidence of inflammation or prior inflammation. And so if we find that, that could be supportive of MS. One thing to note is not everybody needs to have spinal fluid. So certainly if you've been diagnosed with MS and your care team never said to get a lumbar puncture, that's completely appropriate. And this slide here is a reason for why. And so every so often, a team of experts come together in the world of MS and they think about, how are we defining multiple sclerosis? Does that make sense for what we've learned in the years? And so the last time there was a big revision of diagnostic criteria was in 2017. So this here is part one of two different slides that I'm going to show that just show you kind of what we as providers think about when we're trying to come to the conclusion of whether or not someone does or does not have multiple sclerosis. And by no means do you need to memorize or commit this to heart. But I have this up here just to show you how complex it is and what your doctor is thinking about as they're trying to piece together whether or not you have MS. And so most fundamentally, we think about, well, how many events has someone had? And by events, I mean, an attack of optic neuritis, a symptom of weakness of the hand that lasted more than 24 hours that was not a stroke or some other cause, some numbness, tingling of the legs that lasted more than 24 hours and was not some other cause. So you're hearing me say more than 24 hours. And the reason being, in neurology, a lot of these symptoms that people can experience can be transient. But generally speaking, when it's a demyelinating event, the symptoms that come about are typically prolonged, lasting on the order of at least a day. And so that's why that 24 hours is important. And you might think back to perhaps even this morning, if you were leaning on something with your elbow, you have some transient numbness tingling that lasts seconds, you readjust, that's just because your peripheral nerve was compressed. So, we ask questions to figure out if you have numbness and tingling, was it positional? Was it just something peripheral? Or has it been your entire arm's been numb and tingling now for more than a day or so? Because we think about that differently. So if you've had 2 attacks that clinically fit with multiple sclerosis and your imaging is consistent with MS, then your diagnosis is pretty straightforward for someone to make. It's the cases where maybe you've had only 1 attack and 1 event, and your imaging shows some lesions that could be consistent with MS, but not the usual number that we expect to see, or they're not typically in the more traditional area of the brain or spinal cord. That's when we think a bit more about, well, have we ruled out everything else? And do we have enough evidence now to make that diagnosis? And so if we don't have enough evidence based on clinical history or exam alone at this point, what we do is we continue to follow with imaging, and then we think about the lumbar puncture. Do we need to get the spinal fluid to help us make this diagnosis more confirmatory? So this is why this slide here is so important, more so for providers, just when we're thinking about how to make the diagnosis, but I felt would be helpful to share just so it's realized how complex it can be, and in many cases, not as straightforward to really come to that diagnosis. So this slide here applies for patients who will have what we're going to talk about more in a bit, this relapsing remitting MS. But what about patients who really just have 1 attack? What does that mean? So again, we might have just caught MS early, or maybe the patient has a truly monophasic, meaning a one-time demyelinating syndrome. And that's where this criteria, again, can be helpful to help guide the diagnosing neurologist as to whether we have enough information at the present time to make the diagnosis of MS, or does someone fall more into this clinically isolated syndrome camp, which we're going to talk about shortly. Lastly, I've mentioned earlier on that there are different types of MS. And so if someone's had a progressive symptom from the onset, that's where it becomes even more difficult to make a definitive diagnosis. And so you really rely on imaging. And in those cases, if the imaging is not enough, then it's the cerebral spinal fluid that's helpful. So here on this slide, I have an overview of the different disease courses of multiple sclerosis. And so we have essentially starting with kind of the earliest form you can think is clinically isolated syndrome, moving to the more common relapsing remitting, But then there's this other entity of progressive MS, and the term primary progressive and secondary progressive is falling a bit out of favor in some neurology worlds, but I'll just leave them all up here for now because this is still the courses that we use to define different types of MS. So we'll start with clinically isolated syndrome. This is, again, when someone has one clinical event, but their imaging just doesn't have all the features we need to really make a definitive MS diagnosis. And perhaps even with a lumbar puncture, their spinal fluid doesn't have those oligoclonal bands that I mentioned. And so they really fall into this clinically isolated syndrome world. So what do we do with patients that have this as their diagnosis? Well, more recently, there's actually been this growing momentum to treat patients with clinically isolated syndrome, because one thing you might have already started to appreciate is that when MS affects myelin, it causes symptoms. And as I mentioned, MS is multiple scars. So we can't really do anything at this present time in terms of erasing those scars. Once the scars form, they're there. All of our medication approaches right now are preventative. And so as a field, we've really moved to this paradigm of early aggressive treatment, meaning we'd like to give patients the best chance to not accrue disability, to not have relapses. And so with that paradigm shift in mind, there have been some recent clinical trials looking at the use of MS medications for patients with clinically isolated syndrome. And so the two that come to mind that have been most recently published are a medication called teriflunomide, another one called dimethyl fumarate, which fall more in this moderate efficacy. So there's different types of MS treatment in terms of how strong or immunosuppressing the drug is. So there's your low, your moderate, your high. So in this moderate, this middle of the road world, you could argue even dimethyl fumarate perhaps is more on the high efficacy, the stronger side. The studies show that when you treated patients with CIS with these drugs versus CIS patients with some placebo, the patients that were treated with drug actually had less conversion to MS. So they had a delayed progression to having an attack for the second time. And so that argues perhaps the use of medications for MS in these patients that historically were not really considered to be MS patients. And of course, because this is more of a novel realization, for any course of MS, it's really a shared decision-making process with the patient and the provider taking care of the patient to really decide what are the benefits and risks that one individual patient is willing to consider and tolerate to prevent disease accrual, because we actually do not have a great prediction model to be able to know if one patient with CIS is going to develop MS or not. We certainly have ways to estimate that, and we use current imaging at the time of CIS. How many lesions are there? What was the presentation? What's the background of the patient in terms of other comorbidities? Do they have other autoimmune conditions, etc.? We can use that to maybe hypothesize a percent risk, but it's not perfect, and we really don't have a perfect way of predicting. And so if there's someone who's very risk adverse to having a clinically definitive MS come about and wants to do everything to prevent a second attack, that's where medication really makes sense. And now we have the scientific data to really support doing that. So I think that we're going to see in the coming years a bit more of patients with CIS being treated as we treat patients with MS. Relapsing remitting MS is certainly the most common type of MS, and that is when you have a patient who has an event, it gets better, their symptoms kind of improve with time, and then they have another event later. So that's the relapsing part, and the remitting is after the event, symptoms get better a bit. So that's all that really means. And what I have down here is this iceberg analogy that I actually learned from someone who's at Mount Sinai when he gave a talk at a prior MS conference I went to about thinking about MS like an iceberg. So you can see the relapses, that's above the water. What we don't see all that well is that there still is some ongoing disease activity level that's continuing on, whether or not we're seeing each discrete event or not. And so that kind of model just supports the need to treat MS, because even if a patient has an attack, seems to get better, and for some, potentially even back to their baseline before the attack without any residual symptoms, that's great, but there still is some disease activities that that is there. And so that is what supports our recommendation to go ahead and start treatment. Because as I mentioned, our treatment, again, is just preventative. So whatever we can do to make that amount of the iceberg under the water as small as possible, so that way what we see is what is there, is our goal. Because with time, as we age, a lot of our compensatory mechanisms that we have to really hide some of the accrued disability that has happened basically without being seen previously becomes about. So you might see patients who are having these relapsing remitting events later in life show more disability than you might have thought. And that's because the disease was still progressing. And so it just further highlights the reason that providers will strongly advocate for starting a treatment. Secondary progressive MS really is when someone who used to have relapsing remitting events now just no longer has these very discrete, obvious relapses, but is still progressing. So you might just notice some subtle weakness that's going on in time. And in any type of progressive MS, it's not very evident. And so you really need to take a step back and look at a patient over a course of many visits. And then you might appreciate that there has been some subtle ongoing progression. So that is certainly the type of MS that is much harder to monitor. And that's where it becomes so important for patients to really just share their symptoms, share what they're experiencing with their neurologist. So that way we can change course as early as possible to be sure that you're on the right medication for you, because not all of it may be seen or obvious. And lastly, to that point about progressive MS, there is an entity or a type of MS that is termed progressive MS, but a primary progressive. And what that means is these patients never really had your more classic relapses, but through time started to have weakness or spasticity that kept getting worse through time. And it wasn't discrete events, but over a gradual period. And we don't have the best imaging to really find that. Really, we see the relapses clearly on MRI because we see these white scars on the MRI, but we don't really see that with progressive all that much. And so that's, again, where history becomes so important, and making sure that you continue to follow up with the neurologist through time to do ongoing serial exams to really look for change. That's where that becomes important, to really look and watch for progression. Historically, all of the medications that are commonly on the market for MS are being studied in patients with relapsing remitting because it is the more common of the types here. But there have been at least 2 that have been used now in progressive MS types, ocrelizumab being the one that has been approved for secondary and primary progressive MS. So although the studies certainly show a more robust, favorable outcome when they're used in relapsing remitting, we were able to see some slowing of disease activity in patients with progressive subtypes as well when treated with ocrelizumab in some of the trials. So certainly more to understand about this condition and a lot more room to go in terms of finding the right type of treatment for progressive MS. I have radiographic isolated syndrome, or RIS, on its own slide here because there is some controversy about whether or not to even consider this along the MS spectrum of diagnoses. So what is RIS? So essentially it is patients who have imaging findings that for all intents and purposes look like multiple sclerosis lesions, but have never had a clinical event. And it certainly has been well appreciated that there are patients who have imaging that look like MS, but will never go on to have clinical events. But then there are patients who, for whatever reason, had a brain MRI that look like MS, were not started on therapy, later did have a clinical event. Again, we don't have a great prediction model to know who are the patients with RIS that are going to go on to develop MS and who are just going to continue to live their lives without any clinical significance of these lesions. So that's certainly something that, because we can appreciate well, there remains this question as to how do we manage patients who come to clinic with these imaging findings, but otherwise clinically feel well. As you can imagine, going back to the iceberg analogy, you can certainly hypothesize that even though they haven't had a clinical event, maybe these lesions with time will show some clinical significance. And based upon that, there have been trials looking at the use of medications in patients with RIS in the very recent years. So this one publication published just last year was looking at the use of dimethyl fumarate in patients who had radiographic isolated syndrome. They looked at roughly, I think it was about 44 or so patients in the treatment arm and 43 in the placebo arm of patients with RIS. They followed these patients through time. And they saw that over the course of about 96 weeks, they had a decreased occurrence of an attack in patients who were treated versus those in the placebo group. So what that supports is that perhaps the use of this medication actually delays the onset to a clinically definite MS. And so more to come here. It's definitely a hot topic area right now in the field to figure out how to define these patients and how do we decide when to treat. So the next portion of the talk is going to be primarily talking about treatment. So we've alluded a lot to how we diagnose MS and the different types of MS. So now what do we do when we make this diagnosis? So what can you expect? Well, from your neurologist, you are going to be seeing that person quite often, especially at the beginning. One, to really establish whether the diagnosis is correct, and then to follow you through time to understand if your disease is being appropriately controlled, or are you having ongoing symptoms or progression despite medication. You're going to talk about what medication you're on. Are you having any side effects? And also going over any monitoring that you need to do. We have over 20 medications now available for multiple sclerosis, the relapsing remitting type in particular. And each of these medications is a bit different in terms of how it works against MS, what the route of administration is. So what I mean by that is it a pill form? Is it an injectable that you give yourself? Is it an IV infusion? And because of the differences in how they act, there's also a different set of safety labs and monitoring that has to be done to look and continue to weigh the benefits and risks of each of these therapies. Aside from the office visits, your exam, and surveillance, imaging is certainly going to remain an important part of your care because we, one, establish a baseline to get the diagnosis, and then two, we use your imaging findings as a marker as to whether the treatment you're taking is effective or not. So sometimes you could have no new symptoms, but your imaging may show ongoing disease activity, and that would be impetus to then change course in how you're treated. I will share that once we set a baseline prior to treatment, my practice is I typically will get at least a brain MRI 6 months out from treatment start just to set a new baseline. And then a year out from treatment, which roughly is a fair trial of any medication with appropriate adherence, if there's still disease activity a year from being very much adherent to prescribed treatment, that's when I start to think, well, is this the right medication? Should we be switching to something else? Some patients respond better to certain medications than others. Majority of the time, it comes down to kind of what tier of medication was it. Like, for example, if we started with a weaker medication, but you're having more disease activity, then that would just argue that, you know, we really need to bump up to either a moderate or a high level strength medication. Generally speaking, early aggressive treatment is common. And so I do often encourage my patients to start with a higher efficacy or a moderate efficacy treatment. But it's, again, a shared decision-making process. So if overall MS has not been too aggressive through time and a patient prefers to have less risk of immunosuppression, then we start a lower efficacy treatment. So again, it really depends on a conversation between the provider and the patient, but this is what you can expect for how all of these different components of your care are going to be accounted for with each of your visits through time. In addition to your neurologist, or even within your neurology center, there oftentimes are providers of other disciplines available to help and to remain part of your care team. And so, for example, in our clinic, we have our doctors, we have our registered nurses who take care of patients specifically with MS. We have our care coordinators who are very familiar with these patients as well. Other centers may also have physician's assistants or even nurse practitioners. And then we have the infusion center staff for those patients who are receiving IV infusions. There's so many people of your core care team that are looking at you and helping to care for you all the time. I oftentimes also rely very heavily on ancillary services such as physical therapy, which is PT, occupational therapy, or SLP, which is speech and language pathologists, depending on how a patient is affected by their MS, because medication is only one part of the solution. Really, we have to work on strengthening whatever it is that MS has caused. And that oftentimes is through these adjunctive therapies and therapies that are not pharmacological, but rather therapy like physical therapy or occupational therapy. So I find these providers as being essential to the ongoing care of patients with MS. As I've alluded to many times already, MS affects people very differently. There are patients certainly where even at the onset, mood and memory can be something that's very much prominent. And so in our MS unit, we've appreciated this to be the case, particularly after new diagnoses. So we've actually recently hired an MS psychologist who focuses on caring and providing psychological care to patients with MS. And we found this so far to be very well received by our patients. And as a doctor taking care of MS patients, I love that we have our team psychologist as well, because I can very much appreciate the impact that her care is having for our patients. If you've had optic neuritis in the past, the effect of your optic nerve, a neuro-ophthalmologist or even a comprehensive ophthalmologist is also a part of your core team. And then again, depending on what your other symptoms are, you may also have a urologist or even a physiatrist helping with spasticity, for example, by baclofen pumps or Botox injections. So there's so many different providers on your care team. I put dermatology on here just because some of the medications we use do require annual skin checks just for monitoring surveillance purposes, looking for any skin cancers. Again, that's not all medications, but certain MS medications, you do need that too. And so everyone's care team may look a bit different. But what is similar for everyone's care team is the resources that are available for you all outside of the hospital. And so for MS, there are many societies on a national level, a local level, a regional level that patients can connect with to not only learn about MS, but to learn more for how to best treat your own MS. And so there are MS-focused exercise groups. There are community gatherings, there are fundraisers, there are so many different things going on that are available for you. And of course, your friends, your family, your caretakers, those are all really the most critical parts of your care team to make sure that you feel supported. This is a chronic condition, and like with all chronic conditions, comes a level of distress regardless of how mild or severe your symptoms are. And so having a really strong social network outside of your healthcare team is extremely important to keep in mind as best as possible to just live your best life. This slide here is taking us back into the pharmacologic treatment of MS. So what you can appreciate, and the reason I put this on here, is that there's just been a boom of MS medication development in the past 10, 15 years. So much so that these slides become outdated so quickly that I couldn't find one for this year because it didn't encapsulate everything. And so I thought this one was the best to share because it was the most comprehensive. And what you'll appreciate is a lot of our older medications were developed earlier on, tend to be the weaker medications. And as we've learned to really understand the immune system and its impact and its relation to MS, we've developed these stronger medications, which are working extremely well for many patients with MS. But again, it oftentimes is a bit of a trial and assess in that there is not one medication that fits all. And so if on your medication you're having more symptoms, relapses, or you're not tolerating the side effects, it's so important to share this with your provider so that way we can switch to a medication that's right for you. What I don't have a lot of time to spend on in this hour is all the many different aspects that we think about when we're trying to guide a patient for what medication to start for their MS. So I'll just briefly mention that it's important to also share if you have any intentions on starting a family. So for family planning purposes, there are certain medications that we would or would not prescribe to young adults who are looking to start having children. If you have high blood pressure, there is a medication that we wouldn't want to use for your MS because it can cause worsened blood pressure. So there are very different aspects and details of your own personal health and medical life that we take into consideration when we then say, well, I want you to read about medication X and Y. And the reason for that is because of your preference for how to take a medication, your risk adversity in terms of the degree of immunosuppression, and then what personal medical history or characteristics about your future and hopes that you have in mind. So many options, but many complexities for how we decide to then guide you for which medication that we can use for your MS. I mentioned, if you remember back to the earlier slides, that MS really can affect people in many different ways. On that slide, I really highlighted more of the physical results of the different lesions. This slide here shows even more associated symptoms that patients with MS can have, either as direct consequence from lesions or as secondary residual symptoms from prior attacks. or just generally speaking, these gray matter symptoms, again, of the mood and the cognition, and even fatigue could fall into that. And I put this on here wanting to highlight again that you might not experience all of these symptoms or each of these symptoms, but if you do have any, definitely share with your provider because there are things we can do. So this slide, I'm not going to go through each of them, but just shows you that aside from the ancillary services, the therapies that I've mentioned, there are some medications that can be prescribed in the right clinical context to help with some of these symptoms. So please don't feel that if you've had an attack of MS, you're left with symptom X, there's nothing that can be done. We may not be able to reverse symptoms, but we could try to make it better. So definitely share whatever symptoms you're experiencing. Outside of medications that can be prescribed, you might notice on here that I have even vitamin D and exercise and diet and sleep, because lifestyle modifications are equally important and are just a bigger part of your treatment plan that are important to not forget. Because you might imagine that it's really simple for someone to say, oh, of course, if you sleep more, you're going to be less fatigued. But there's a lot of research showing that getting optimal sleep is just good for our overall brain health in terms of memory as well. Exercise and diet is certainly important for your overall medical health, but as well as your brain health. So we see that there is less progression to cognitive impairment or memory issues like dementia and such in those who exercise regularly or have a healthier diet. With that, vitamin D is really important. Sometimes vitamin D deficiency can present as depression or present as this really profound fatigue. So it's important to consider that and to look for that, and if it's present, to supplement it. The next few slides, I'll just talk a bit more in detail about some lifestyle modifications that your provider may go over with you. Generally speaking, being healthy is, of course, always good, but there is some very concrete evidence showing that a healthy body mass index, a BMI, is associated with decreased risk for MS-related disability, as well as reduced relapse rates. If you manage your comorbid hypertension or cardiac conditions, it's also important because it's actually found to lessen relapse activity or disease activity. And the thought there is that with obesity or cardiovascular conditions like high cholesterol, hypertension, that confers some element of an increased inflammatory state, which then, as you would expect, would cause more increased central nervous system inflammation and therefore translate to some disease activity. So if we can manage these things, it's all an effort to try to control our inflammatory baseline to help us make our MS less active. Along those similar lines, there's been a lot of research in the past decade or so looking at something called the microbiome. This is essentially the natural bacteria, the natural gut flora that we have. Our diet really much informs what that gut flora is. And research has shown that there are particular species of gut flora that are pro-inflammatory, meaning that they are causing a heightened state of inflammation, or anti-inflammatory, meaning that they're actually lessening inflammation. And so what we find is certain diets actually help to modulate the microbiome in a positive way for MS. There's a lot of work being done in that field. And we've talked a lot about vitamin D, so I won't go over it again in too much detail, but just know that it's so important to supplement for the purposes of decreasing relapse rate, as well as even risk of developing MS. So to say a bit more, sometimes patients will ask me, well then what diet should I take? There really isn't a best diet, but what I will share with you is at a lot of the conferences that I often attend each year for multiple sclerosis, the Mediterranean diet, time and time again, seems to be the one that's discussed. And in the contexts that I've seen it talked about at these conferences is that people who are adherent to the Mediterranean diet with multiple sclerosis tend to have less cognitive impairment later in life. So potentially there is a role here for a Mediterranean diet in lessening any sort of degenerative process that could then impact cognition. Similarly, there have been some studies to show less gray matter atrophy. Gray matter is just another part of our central nervous system. So again, arguing that this Mediterranean diet actually could be really helpful from a physiologic approach as well. So what is that? That tends to be your green vegetables, your fruits, your nuts, your fish, your lean meats, your chickens, things of that nature. So I often advise patients just to stay away from high fats, your traditional burger fries diet, and to choose more natural, healthy, well-rounded diet, everything in moderation. And then lastly, your vitamin D supplementation In addition to prescribing MS medications, I prescribe vitamin D for all of my patients. The range varies, depend on kind of what their levels are and their just general sun exposure, etc. But rule of thumb, I would say that on average, most patients are taking at least 2,000 international units of vitamin D3. So if you have MS and your physician has never talked to you about vitamin D supplementation, certainly feel free to ask because it is something that's pretty widely recommended in general. And then lastly, a bit about exercise. You know, of course, everyone preaches exercise is good for you, but it really is. Not only is it helpful for strengthening, it helps with mood and with fatigue. And in neurology, it's really been shown to help with memory, both within MS patients and non-MS patients. So many benefits to exercise. And it doesn't have to be that you're running the marathon every year, but even 15, 20 minutes of exercise on a regular routine basis, just whatever you can do to get going, even if it's just very low intensity exercise, some yoga, some stretching, any exercise is really good for you. It's important to stretch, stay hydrated. And, you know, if you're finding it hard to get started, talk to your primary care provider about even a referral to physical therapy. They can give you treatment plans for the sole purpose of conditioning. So certainly don't hesitate to ask for help. I have learned from some of my patients that there exists some MS-focused exercise or even MS-focused yoga groups that they found on the National MS Society. So take a look there as well. And then lastly, other things that you can do on an individual level are to abstain from smoking. If you are a smoker, to try to quit smoking as best as possible. And the reason being direct cigarette smoking as well as secondhand exposure has been shown to increase the risk of developing MS as well as heightening disease activity and progression. Sleep is also critical. And alcohol, I am asked a lot about my patients, well, does this mean I can't drink alcohol? And it doesn't necessarily mean that, but I would say you should drink in moderation only. One thing that's important to note is there is this phenomenon called recrudescence, which essentially means that a patient who has had a neurologic attack in the past, whether that's from MS or a stroke or whatever it is, when your compensatory mechanisms are down, which is what happens when you are sleep deprived or when you are not eating appropriately and not maintaining adequate nutrition, or if you're drinking alcohol, old symptoms that you have had because of prior insults will become more apparent. So for example, you might notice that if you have some residual baseline vertigo from your MS, if you drink alcohol, that might bring it out. So just kind of keep everything in mind in terms of what you can tolerate yourself on an individual basis. But again, moderation is key. So here, just to summarize kind of the treatment component of this talk, I just want to leave with kind of 4 main takeaways from what I would recommend that if you were to take away anything from today's lectures, keep this in mind. If you get a diagnosis with MS or you are a caretaker for someone with MS, the number one most important thing is to be sure that you have a very supportive network. And this is with your care team, to be sure that you have a neurologist that you feel comfortable approaching, sharing your symptoms with, being open with about family planning, whatever it is that's going to influence how we can best take care of you. Because we want you to feel comfortable asking questions. And the information we learn about you is helpful for us to be sure that when we prescribe you a medication, that we have the best chance of actually treating your condition. Because if you're prescribed a medication for MS that you ultimately are not comfortable taking, we don't want that. We'd rather you take a medication that you will be comfortable taking to treat your condition, even if it is a different one than what we initially planned on. So definitely, you know, feel comfortable to ask questions, to express your preferences, to be sure that you feel comfortable with your team. The second most important thing is really putting it on the individual, that it's so helpful to give yourself time, especially if you have a new diagnosis, to just know that this is hard and it's going to take some time to know how MS affects you. It's really challenging even for providers sometimes to discern if a symptom that someone reports is from MS or not. So ask. If you experience something, it's never a bad question to just say, hey, I'm having symptom X. What is this? Should I be concerned? Asking is the best thing to do. If you are aware of any referrals for therapists or local supports, use them. Even if you don't think that they're going to help, they could. And each symptom that you have is just as important, no matter how mild or severe. And so we have these mechanisms in place to help take care of you. So definitely feel free to use them if you're interested. And again, share whatever observations you have about yourself, any new symptoms, any changes, and share that early. Because as I mentioned, our medications are preventative. So the sooner we know that things are not going as we would want, the better we can then treat you in the future by changing course when needed. So in the final minutes, I'm just going to wrap up and just kind of take a very broad overview with some areas of ongoing research in MS, and then we'll have some time for questions. So today we covered just overall what is MS, what causes MS, the different diagnostic categories, how do we treat MS, and what does having MS mean for you in terms of what a doctor's visits look like and who's there for you. So as you can imagine, we don't know everything about any of these different components. And so I've broken up those different areas on this slide here. And, we're really looking into various different questions for each of these kind of parts of multiple sclerosis. So as I mentioned earlier, there was that nice study from the VA about EBV. So there is a renewed interest now in looking at some implication of a viral pathogen in MS. Again, not really a novel idea, but something that's regained some interest there. So a lot of studies. Clinically isolated syndrome and radiographic isolated syndrome together, there is a lot of research pouring into, well, what are these conditions? How do we define them? Are they appropriately on the MS spectrum? And if so, should we be treating them? So more to come there. For the treatment of MS, we're going to continue to have a lot of medications being developed for relapsing remitting just because it's so prevalent. But reassuringly, in the past several years, we're starting to get more medications being studied in progressive MS. So I hope that that will continue to be ongoing. And I know of many studies that are looking at using various drugs for remyelination, which would be the repair of myelin. So more to come there. Stem cell therapies in the past 5-10 years or so have been discussed in MS, have been studied, and that is still an ongoing area of investigation. And then kind of contrary to a lot of the things we've talked about today, there even is an area of research looking at, well, when do we decide to step down from MS therapy? For example, you've had MS since your 20s, now you're turning 80. Do you really still need to be in immunosuppressive therapy? So there's a lot of research looking into that. Is there kind of an end date for treatment? Because generally speaking, the practice now is we treat until the risks outweigh the benefits, because we don't have a great way to predict when the MS is no longer a concern to worry about. Although generally we would imagine that as someone ages, their immune system becomes weaker, so their MS should become less active. So that is an area of research as well. And then imaging, there's always research looking for how to improve the technology we have. There are several trials going on for imaging in particular here at Mass General. So if you're interested in learning more or partaking in this, certainly hop on the MGH website. And you will find some more information about what's available to you, or ask your current doctor or your current care team about any ongoing studies that if you're interested in contributing. But there's a lot to learn and a lot to come, a lot of questions to ask that we're not even aware of yet. So still much to learn from the patients and just from the field in general. So in closing, takeaways are that MS presents differently for everyone, depends on where it hits. Your treatment really requires a multifaceted approach, and share symptoms early, take advantage of what's offered, what's out there, but also understand that right now we are a bit limited in that we're still working to understand the cause and how to best treat, and to know what the best treatment is for everyone. But we certainly have some preliminary idea of at least how to modify some easy day-to-day lifestyle components and medications in terms of things that we do know work, and starting to apply to these more earlier phases of MS. So I want to thank you all for listening. I know we covered a lot today, but I'm happy to take any questions that you may have.
Thank you so much, Dr. Manzano. We are now at the end of the session, so if you have any questions, feel free to enter them in the chat. Dr. Manzano, I know you talked a little bit earlier about how there is no best diet for MS. However, you touched upon Mediterranean diet that can be beneficial, or vitamin D supplements. Is there anything you'd like to add to that?
I would say, and not to always go back to the National MS Society, but they actually have a beautiful page about some common diets that have been studied. You will notice on there that there is this protocol for high vitamin D3. In my opinion, is that is not so helpful, and there are some risks there. So I would say whatever diet that you read on that website, it would be important to talk with your provider about, just to make sure it's the safe and the right approach for you. But one that is safe for everyone is the Mediterranean diet, and certainly is helpful for conditions outside of MS, so for cardiovascular health, etc. So it is one that's very widely accepted.
Are there any reputable resources one can go to learn more about the Mediterranean diet?
Yep, from the National MS Society, there's a nice link on there, actually. It's the most common organization, so I think that's why everything seems to be on there.
Great. And does MS affect one's life expectancy?
That's a really great question. I would say that historically it did, because we didn't have the best medications to prevent more disability and more relapse. And so patients who developed MS in the 80s, or perhaps even the early 90s, sometimes we weren't able to really stop progression. And so it did. But I would say now many of my patients and many MS patients worldwide can live a fairly uneventful life if they're diagnosed early, treated early. Of course, that's not the case for everyone. Some people may have very severe disease from the onset, but generally speaking, we don't really expect it to shorten a life expectancy.
Thank you. You briefly talked about family planning. For women with MS, can they safely have children? What are some special considerations?
Okay, great question. So the condition itself actually is not the issue. In fact, patients that have multiple sclerosis that become pregnant tend to actually have less disease activity. So in a way, pregnancy is protective, as is breastfeeding. For women with MS, it's very rare for patients to have disease activity during pregnancy or in that early postpartum phase. But where family planning becomes important is thinking about which medication to take. So there are some options. You again should talk to your provider, but generally speaking, using a weaker medication can be an option for people. So for example, Copaxone or interferons, but I would say that's really if we're really worried about a patient's level of disease activity prior to becoming pregnant. Majority of patients could actually come off of treatment during pregnancy. And that's where it becomes important to try to time. And it's not always as straightforward and easy as that. You can't always plan, conception when it's going to happen. And so in certain cases, we work with OBGYNs to work on family planning to try to time things out well. And if you're on infusion therapy, that lends to a bit more planning ability. But what's important is if you're on a medication that we know has some fetal risks, to share with your provider that you would like to start to become pregnant, because we would need to stop some of the medications. And there's even one that needs a washout period, meaning we would have to give you a medication to be sure we remove that medication from your system so it doesn't cause any harm. And that goes for both the women and male partners too, for that one medication called teriflunomide. So if you're on a medication, or if you're not, and you soon will be, definitely just share with your neurologist what your plans might be.
Thank you. Can patients with relapsing remitting MS have long-term symptoms such as spasms or fatigue?
Yes, definitely. So, I would say that relapsing remitting sometimes is even a misnomer, right? Because sometimes the remitting phase is not back to baseline and there are some residual symptoms. And so the residual symptoms of spasticity are often present because whatever the scar is, wherever it is, oftentimes in the spinal cord, it didn't fully heal enough to take everything away. And so if you are experiencing that, definitely share. The fatigue is something that's thought to be present in all different types of MS, as is the mood and the memory. Again, not everyone has those things, but regardless of what type of MS you have, those symptoms are possible. So if you're experiencing them, share, and your provider will investigate, is it because of the MS, or is there actually something else that is reversible that we can just easily fix without a treatment medication?
Thank you. While we wait to see if there are any additional questions, are there any final thoughts you'd like to share with the audience?
I think the final thoughts would just be thank you for listening, and definitely feel free, to use the resources on our website. And yeah, I hope to meet some of you in another forum for patients in the future. But yeah, thank you. Thank you so much for listening and attending.
Thank you so much. And for anyone who are interested in viewing the recording of this presentation, feel free to visit the Blum Center website at massgeneral.org/Blum-Center. It'll be posted within the next few weeks. Thank you so much, everyone. Have a lovely rest of the day.
Thank you. Bye, Amy. Thanks so much.